Hi everyone, today we'll talk about the recorded lecture for the knee, which is chapter 21. And first and foremost, make sure you review all the anatomy structures that we went over in PTA 150. So that way you are more familiar with the procedures for post-op treatments and etc. The erythrokinematics, as far as also make sure you review what a screw home mechanism is, the Q angle, and patellar alignment, tibiofemoral alignment. All of these mechanics of the patellofemoral joint are very important in all of the structures. So make sure you review all the anatomy. So as far as referred pain and nerve injuries, but I'm going to kind of talk a little bit before that is how in your textbook talks about patellar function. So the alignment, a lot of people might have patellar tracking issues, especially those that are female and potentially younger, especially athletes, and increased Q angle and weak quadriceps muscles and weak hip abductor muscles. Therefore, they could have a misalignment or an increased Q angle and have more issues with patellar tracking. So make sure you review that information as well. For the knee and gait, there's, of course, anything from the ground up. So foot impairments, from the foot and the ankle, if someone is more pes planus or pes vagus, or if they have an overall medial rotation of lower extremity, they could have an increased Q angle and then increased bowstring effect on the patella itself. So from the ground up, gait can really change as well as for the hip and the knee. If there's any kind of hip flexion contractures, we'll have the inability to extend the hip and prevents the knee from extending just before terminal stance and heel off, and length and strength imbalances. So if there's any kind of asymmetries between the hip and the knee muscles, as well as the gastrocnemius, the soleus, the IT band, all of these, there could be an occurrence, or if they have a tight hamstring. But make for sure you review all of that from anatomy. So we're going to talk a little bit, there's some different kinds of, there's major nerves that supply the knee, and common fibular nerve is pretty common as far as either from injury or even from surgery. I've had patients that have had postoperatively, damage to the common fibular nerve, and they might have foot drop. They might have to wear an AFO, even if, it takes a really long time for that nerve to heal, if it heals at all. So look over that information. So common joint pathologies associated. We've talked a lot about osteoarthritis before, degenerative joint disease. So obviously they're going to be limited in range of motion. They'll more than likely lose flexion overall, more so than extension. They could have periods of effusion, swelling within the joint. And therefore, too, if there's any kind of swelling in the joint, it can have an ability to perform full knee extension or flexion as well. So it depends on the severity of OA, if it's minimal, moderate, or severe. So the end stage of arthritis, it could be to where they might have, if they're not able to participate in leisure or household activities, they're not able to perform ADLs, maybe such as ascending and descending stairs or squatting. All those different types of things might be to where they will get a total knee replacement. So make for sure you look over, all the common activity limitations, and also some other thing too. They could have impaired balance, increased body sway. They could have different postural and abnormalities and muscular abnormalities as well. So talking about for a non-operative management, so protection phase. So patellar tracking, prevent patellar adhesions, especially for OA. Just trying to improve range of motion and decrease pain, and starting with a base of, doing isometrics to improve quad control, hip abductor strength. So we'll kind of start off with that, with especially decreasing the pain. Then as you get into the controlled motion and return to function phases, so it's pretty broad how they describe in your textbook, but teaching the patients to do safe exercises to do at home, improvement. Obviously, we're not going to improve osteoarthritis completely, but having them become more functional, describing that to them, having them being able to maybe decrease their pain. Maybe they're now able to walk more prolonged distances. Maybe they have more increased range of motion from therapy. Maybe more control overall, gait training, able to perform more ADLs. And so just a more functional and healthy lifestyle in general. Some other things as far as not just education, but strengthening, stretching, range of motion, endurance activities such as like a recumbent bike. All these different things will help with improved range of motion and to improve overall performance. So increased joint play and range of motion. So it's a precaution to not increase range of motion unless the patient has sufficient strength to control the motion already available. So that's kind of, communicating with your PT, evaluation, reevaluations to figure out as far as making for sure that they have stability as well as mobility. So joint mobs can be used, but really, have to follow all of the joint mobs, the precautions and contraindications with that. But patellar mobs are pretty important to make for sure that they're, putting in or having the patella in all directions for patellar mobs just to improve mobility. So make for sure that you look over the different types of grafts, and especially when we talk about the ACL, there's different graft options for that as well, especially such as using like the tendon of the hamstring. So all that's going to make a huge difference when it comes post-operatively. Now, to total knee replacement, there's different types of total knee replacement and surgical approaches. I've seen a couple different surgeries, and it's amazing to see what one surgeon will use compared to another. But amazing as it is too, I love total knees and post-operatively with that. So it's kind of a sequence, and just making for sure though of complications. So there could be complications to where with any surgery, DVTs. So being aware of DVTs and what that would look like. Some other things too would be, hopefully they're not building up too much adhesions and scar tissue and limited range of motion. So that could be a complication. Maybe they're not coming to therapy. They're not, performing their exercises like they should, and they're not progressing and increasing their range of motion for flexion and extension. Then eventually they might potentially have to have a manipulation surgically. Let's see, some other things total knee. Some other things would be, I've had patients have issues with being allergic to the actual surgical parts and having to have that surgery all over again and having different parts because of allergies. So total knee arthroplasty, your textbook describes it. It's pretty similar to, like as far as the healing phases and in general, but there's different issues like if early mobilization like CPM, a continued passive machine. Now there's been some contradicting evidence to say, oh well, initially does that really help? It really depends. Are they utilizing that only and they're not performing enough gait training, or are they not performing other exercises as well? Are they performing the CPM machine correctly, or is it towards the end of the bottom of the bed and they're at the top of the bed and they're not getting as much range of motion with the machine? But there's a lot of studies that have shown that post-operatively, maybe not initially, but later on down the road, they have pretty much the same outcome. So you can read over that as well. So the other thing about CPM is including a decreased need for post-operative pain medication, which is huge, and decreased incidence of DVTs, and more rapid recovery, but as early mobility is shown to be equally effective in realizing these benefits. Okay. Weight bearing too, so following a total knee arthroplasty depends on the prosthesis, the implant, the fixation, the patient's age, size, the bone quality, whether a knee immobilizer is worn during ambulation or transfers. So all that's going to really depend on the surgeon and what type of prosthetic they're going to use. But typically, they could be just toe touch weight bearing or partial weight bearing for the first 48 weeks. while using crutches or a walker. So really making for sure that they have good quad control is probably the biggest thing with gait training. If their knees buckling while they're walking with a walker, if they demonstrate extension lag with straight leg raises, all those things are going to be poor quad control, and they would not be appropriate to ambulate without an assistive device. And the other thing with that too is if they have what if they have poor balance? So that's going to take an effect too, to where they would not be safe without an assistive device, especially if they use assistive device prior to surgery. Then that's going to probably be a longer recovery if they even get off of the walker, if they had, or assistive device if they had that before. So tissue healing, just like with anything else we've talked about, making for sure that we do not interrupt tissue healing. It's kind of different with the total knee replacement too. Some things are pretty progressive, especially at the beginning, just to improve the range of motion of the knee, and just in general, just trying to get them rehabilitated quicker, especially now and just in general and post-operatively. You want them to be pretty functional and being able to discharge from the hospital home for home health and be safe enough to ascend, descend stairs and walk a prolonged period of time based upon their setup at home. So some different goals and interventions that could be possible as prevent vascular and pulmonary complications. So there's going to be different things too, like ankle pumps, especially immediately after surgery to reduce the risk of DVTs or pulmonary embolism. Deep breathing exercises, controlling the pain and the swelling, using different modalities such as cold compression and having them elevate. So muscle settings for the quad is preferred with a neuromuscular electrical stimulation. Hamstrings and hip extensors and hip abductors. Active assisted straight leg raises and supine and prone the first day or two after surgery, so that way they don't have extension leg. Then you would progress them to active range of motion, seated and standing for anti-gravity, knee extension, and flexion. So all of these, make sure you look over. We'll talk a lot about these more so in lab. Some different things too about pain. There's a lot of patients, and it's normal. They'll have more pain at night. They have difficulty sleeping. They might have to be sleeping in a recliner for a while. A total knee replacement is pretty painful, and so just communicating with that it is painful and trying to control their pain, maybe talking with the physician, having them talk with the physician and how to control the pain, to manage it. That way they can make progress with therapy. So talk more about patellofemoral dysfunction and patellofemoral pathologies. So they could have pain and malalignment, they have instability. So this is a great picture too. Even if you had, this individual ascend, descend stairs, and you see this increased Q angle from the hip to the knee to the ankle, you're going to try to help realign, and you're going to have to strengthen these hip abductor muscles, strengthen the quad muscles, and see how stable the patella is. If you do patella mobs and you realize that it's very hypermobile and they don't have a lot of stability, you're going to be doing different exercises with that. Some other things too, you might be doing hip adductor strengthening. It just depends on where they are weak. I usually tape a lot of individuals, like the condyle taping, kinesio taping. Some individuals might even need a brace with kind of like a half lunar moon to support the kneecap and preventing it from, becoming out of alignment. They could have subluxation issues, dislocation issues. So, let's see. So for increasing flexibility and restricting tissues, doing patellar mobs, medial taping of the patella, patellar taping. So all these different things would be all included as far as trying to improve performance. So for patellofemoral, they could be non-weight bearing open chain exercises. You can do closed chain exercises to improve muscle performance. Again, we'll talk about those during lab. So if they have to have surgical options, so you can read over that too. Just going to go on down. So now talking about more so of ACL, PCL, MCL, LCL. We talked a lot about as far as the mechanism of injury in 150. So make sure you look over that. And we're going to talk about more so of what that looks like postoperatively, looking at protocols and, postoperatively. I know this is talking about non-operative. So non-operative, so maybe they don't have, maybe it's an ACL sprain, right? There could be, so really going to depend on the patient and how much pain they have, and trying to take them through the sequence of passive range of motion, active assisted range of motion, active range of motion, stretching, and isometrics at the very beginning phases. So there's hormonal differences too with ligament injuries. So make sure you read over the information too as far as hormonal differences and associated with trauma and also with age as well. Okay. So as far as ACL reconstruction and procedures, there's different surgical approaches, graft selections. So make sure you look over the different grafts for that. And the mechanism of injuries, make sure you review what the mechanism of injury would be. We kind of talked about that before. Okay. So I know that was pretty quick. I feel like during lab, we'll talk a lot more as far as like looking at the protocols for patellofemoral syndrome, or even IT band can be associated, IT band syndrome associated with patellofemoral. Then also we're going to look at total knee replacement and ACL reconstruction as well. So please look over all of these different surgical repairs and in your orthopedic textbook as well, and we will discuss more on at lab. Thank you guys. Have a great day.